Thank you. Thank you to Ruben Mososian and the remaining the steering committee for inviting me. It is a great honor to speak again at this conference. I think this is the 17th year I have been to Russia, and the improvements I have seen have just been fantastic. And I think what's good is we overcome our political problems and we overcome COVID, and we are here together to continue working together. We keep this for the future. I think the future is bright. I will be speaking about imaging of the systemic and the pulmonary veins. Again, thank you for inviting me. We've heard many excellent lectures about surgical management, but before the patient gets to the surgeon, the cardiologist, the echocardiographer needs to make the proper diagnosis. So that's what we'll talk about for the next 30 minutes or so. I'd also like to give tribute to Professor Alexei Michishvili. I met him, had the privilege of meeting him twice. Both times he educated me and enlightened me about much of the history of our field, and I think he, as we know, is not just a physician of Russia, but he's a physician of the world. And he did a marvelous job with this, and I'd like to give tribute to him also. So, what will we discuss today? We will talk about snowmen, top hats, whale tails, keyholes, vice, both types of vice, make it difficult for the translators, crabs and pearls. So, snowman, whale tail, top hat, keyhole, vice, both types of vice, crabs, and some pearls. So, embryology of the pulmonary veins we've already heard quite a bit about. The systemic and the pulmonary veins are connected to each other initially via the splanchnic plexus. And the pulmonary veins join together to form a common pulmonary vein which grows towards the heart. So it's not surprising as this occurs, and then eventually the connections to the systemic veins disappear, that you end up at term with normal connections. What happens when they're abnormal, we'll talk about in a second. It is normal for most of us to have two veins on the right and two veins on the left. However, about 25% of us have only one vein on either side. Left side more common than the right side, and very, very small number, 1 or 2%, have three pulmonary veins on each side. The venous system is not just the pulmonary veins, it's also the systemic side. The vitelline system forms the portal vein system. Umbilical vein carries the oxygenated blood from placenta to the fetus. This disappears after birth. Cardinal veins form superior vena cava. They form the brachiocephalic veins, the azygous and the hemiazygous veins. And all of these veins are important when we talk about pulmonary vein anomalies, because the pulmonary veins can connect to any of these veins. So there are no complete rules that pulmonary veins can only connect to one place or the other. They can connect to any of these veins. But with echo, that's the primary tool we use these days. Many views. Upper left are subcostal views in frontal and sagittal, where we can see superior vena cava and then entrance of the right upper pulmonary vein. Frontal also, you can use parasternal long axis to see left pulmonary veins at the bottom. And then from the suprasternal notch, very important to look at all of the veins entering the left atrium. And we'll see examples in a second of what happens when there are abnormalities. So subcostal, again, SVC, right upper pulmonary vein. This is a very important area also when talking about sinus venosus defect that we'll talk about in a second. So subcostal sagittal, very important view to try to obtain, and you get this in a neonate very well. Not so much in an adult, but in a neonate you can do this. Long axis views, that's a good place where you can see left pulmonary veins at the bottom of the left atrium. You might see a dilated coronary sinus if they connect to the coronary sinus. And then short axis is also parasternal short axis. You see the aortic valve in the middle, left atrium. You can see left pulmonary veins. You can see right lower pulmonary vein. The thing you have to be careful of when you do imaging is that this is not a pulmonary vein. That is the left atrial appendage. And sometimes you can see flow in that also. You need to make sure you don't make the mistake of calling that the left upper pulmonary vein. Four-chamber view, those are the lower veins. Right lower at the top, left lower here. That is a horizontal type of scanning plane, and if you see the leaflets of the tricuspid and the mitral valve, then you are looking at the lower veins, the right and the left. Finally, suprasternal notch, or something that we call the crab view. You can see all four pulmonary veins below the pulmonary artery, and here's the anatomy specimen, left upper, left lower, right upper, right lower, coming to the back of the left atrium. And you can see how this looks like a vein in the pathology specimen, because that is where the common pulmonary vein has become incorporated into the back of the left atrium. So crab view, like we have over here. Look at this carefully, we're going to come back to it. This is an abnormal crab view, all right? So keep that in mind for later in the talk. And again, be careful about left atrial appendage. It is not the left upper pulmonary vein. You need to be careful when imaging this. Avoid mistakes that I have made and many others have made. You have to stay very organized. Look at all the different views, subcostal, parasternal, four-chamber, suprasternal notch up in the neck. You need to show it in 2 dimensions. You need to show color flow and also spectral Doppler flow. And remember, this is not 1975. If we don't get all the answers with echo, we have other very good tools, CT, MRI, TEE, depending on the age of the patient or the size of the patient. So let's look at a CT. Normal pulmonary veins, you see aorta, pulmonary artery in these cross-sectional views, left, right. And as we advance through, you'll first see left upper pulmonary vein coming in. Nice normal. Right upper pulmonary vein coming in. Left lower pulmonary vein is interesting. It always goes over the top of the aorta. So sometimes after repair, people are concerned that there's stenosis here because this goes over the top of the aorta. And then right lower pulmonary vein. So again, normal anatomy by CT. CT is very useful regardless of the age of the patient. We sometimes even do it in newborn babies. Let's see. Can you advance me 1 slide? Thank you. So you saw this before. This is the normal embryology. What happens when there is total anomalous vein? This common pulmonary vein does not join the back of the left atrium like it's supposed to. And that leaves us with this type of situation. Where are the pulmonary veins going to go now? Maybe advance one, please. Thank you. In this case, they connect to what's called a vertical vein, which then goes to the innominate vein. There's no connection any longer to the back of the left atrium. If you could advance again. Thank you. We've seen this before. There are several types. You can have total anomalous vein supracardiac, cardiac, where the common pulmonary vein connects to the coronary sinus, infracardiac, where the common pulmonary vein connects via a vertical vein below the diaphragm into the ductus venosus or into a portal vein. There's a fourth type, mixed. Mixed does not have a common pulmonary vein. That may be why there are problems with stenosis after repair of mixed total anomalous veins. There's not a common pulmonary vein to either open or to use a sutureless technique with. But these are the 3 more common ones. 1 or 2 slides on fetal diagnosis. This is where it can start. Okay? This was a review from University of California, San Francisco, Dr. Silverman from about 6-7 years ago. This is normal. 4-chamber view in a fetus. This is the spine, descending aorta. See how close the back of the left atrium is to the descending aorta? Very close in a normal situation. This is a fetus who had total anomalous pulmonary venous return. See the great distance there is? much more distance there. So this is a relatively simple imaging tool that as a fetus, we can figure this out ahead of time, that this baby will have total anomalous veins. It doesn't tell us whether it's supracardiac or infracardiac, but at least gives us a clue that there's going to be a problem. All right, this is the top hat. Frontal view, subcostal, you see this. This is the pulmonary vein confluence, the common pulmonary vein. And this is a vertical vein that we'll see here also in a second. This is the vice, not that type of vice, but this type of vice. This vein will get squeezed in between two structures, between the pulmonary artery and the bronchus, and that will cause the obstruction that Dr. Konstantinov was talking about in his lecture. If this connects to the cava, to the left SVC, it'll be anterior to the pulmonary artery and will not be obstructed. But if it gets caught between here, that will cause obstruction. And that's important for us to see when we do echo on the newborn baby. So clues are, if right ventricle is big and superior vena cava is bigger than the aorta, and the pulmonary artery is bigger than the aorta, start being suspicious that something is wrong with the pulmonary veins. So here's parasternal long axis, big right ventricle. This is suprasternal notch. SVC is here. It is as big or bigger than aorta. Pulmonary artery is also as big or bigger than aorta. So we're suspicious something is wrong. Big vein over here, and you see, this is from suprasternal again, flow going towards the head. Always abnormal to see red or blood flow towards the head. So this is a big vertical vein connecting to innominate vein in a baby with supracardiac total anomalous veins. So you turn on the spectral Doppler continuous wave and you see this high flow. This is 2.2 meters per second. That is high. You should never see velocity that high in the pulmonary veins. So you know something is wrong with this patient. Here is confluence, and you see the flow come up, and it is obstructed here, and the still frame easier to see. Nice and laminar red, all of a sudden it aliases, and you can see where there's going to be obstruction there of the pulmonary veins as they get caught in what's called a vascular vice. Chest x-ray, still useful. You see a large circle and a large circle. Angiogram, you see the pulmonary confluence, the large vertical vein. This is the thing people have called the snowman sign, okay? Big circle, big circle. This is the vertical vein, the big innominate vein, the big SVC. They give you the head of the snowman. All right, let's move to the whale tail. This is the image again, subcostal, newborn baby. Make sure we know what the where the atrial septum is. This is not atrial septum. Right? That is part of coronary sinus. So this is where we get confused in newborn babies with total anomalous veins to the coronary sinus. We get confused about where the atrial septum is and where the plane of the coronary sinus is. So be sure to distinguish those two. And you can see this looks like the back of a whale tail. Infracardiac, here's an anatomy specimen. You see the veins coming down below the diaphragm, diagram of the same thing. The confluence is important. Horizontal when it is cardiac or supracardiac, usually vertical when it is infracardiac. Important to tell the surgeon this if we can see this. This is typical chest x-ray of a newborn baby with infracardiac total veins that are obstructed. Heart, hard to see, is small, and pulmonary edema on both sides because pulmonary veins are obstructed. CT shows nice picture of the vertical confluence, and you can see where the veins connect into the portal system. Again, that was a newborn. Diagnosis can be made before we even start looking at the heart. This is liver. And all we did was he turned on the color in the liver. You should never see alias flow like that in a newborn baby. So we have not even looked at the heart at all. We already see something is unusual in the liver. 2D, there's a big vein coming down. Let's go back one slide. Big vein coming down here. Here's the flow, again, flow into the liver from the chest. This is the diaphragm here. Should never see flow from the chest into the liver. And again, we've not looked at the heart at all and already made the diagnosis. I'm going to switch over to partial anomalous veins for the next few minutes. Be suspicious when the right side is big and there's no ASD. That's first clue that maybe several of the pulmonary veins are abnormal. So here we have four-chamber view. Right atrium is large, right ventricle is big, short axis, big right ventricle. Common partial anomalous pulmonary vein problems, the left pulmonary veins to just a vertical vein, so just the left ones to that vertical vein that we saw before with total anomalous veins. You can also have veins going to the coronary sinus, and something called scimitar, which Dr. Konstantinov talked a little bit about before, where we can have one or even all of the right pulmonary veins connecting to IVC. So these are all things to make sure we look for. So here again, this one doesn't look so bad. Right ventricle, not too bad, maybe a little bit big, not as big as the previous one. Well, let's take some pictures, suprasternal notch. This is a nominate vein. What is this? Again, red flow coming towards the head, always abnormal. So this is left pulmonary veins connecting to the innominate vein through a vertical vein. Innominate vein, vertical vein, the pulmonary veins you don't see in this picture. And that's an angiogram of the same thing. In this case, left upper pulmonary vein, innominate vein into the vertical vein, and then into the innominate vein. Sinus venosus defect. First thing to remember, it is not an atrial septal defect. Okay? The hole is not in the atrial septum. The hole is between SVC and right pulmonary veins. We classify it sometimes as ASD because the shunt is at that level, but technically it is between the pulmonary vein and the superior vena cava. It makes up less than 5% that we call having ASD. You can have superior, you can have posterior, usually has a partial anomalous pulmonary veins, and will cause right-sided enlargement. This is that subcostal view that we talked about before, subcostal sagittal, SVC, right pulmonary artery, and you see the defect here of the sinus venosus defect. When we do TEE, we can see something called a keyhole sign. You can see this with TEE or with CT. This is SVC. This is right upper pulmonary vein connecting to SVC, not left atrium. And it forms this keyhole. In a diagram, that's what it looks like. Right upper pulmonary vein to SVC. And then by CT, you can see the same thing here. Right upper pulmonary, right upper, right middle, going to SVC. So CT, echo, same images. Keyhole sign, sinus venosus defect with partial anomalous pulmonary veins. One important thing to tell the surgeons also, they will want to know what is the relationship of right pulmonary artery to where you see the veins come in. If it's high up, they have to approach it differently than if it's low by the SVC RA junction. Warden operation or not warden operation. There are other talks coming up about the warden operation. This is what one looks like after surgery with a CT. SVC, you can see here's the anomalous vein that they left, and now it connects to left atrium. The patch is not here, the patch is in the middle of the atrium. They leave sinus venosus defect open and just allow that to be the pathway. A word or two about scimitar syndrome. Again, as shown before by Dr. Konstantinov, right pulmonary veins connecting to the inferior vena cava. It's associated with anomalous arterial supply to the right lower lung, and the right lung may be small. Part of the right lung may be small. It's called that because of the scimitar, the chest x-ray finding, the Turkish sword. Most of these patients, that's all they have. They don't have any other cardiac issue. About 25% may have ASD, VSD, coarctation, tetralogy, but 75% have nothing else wrong. And that's why sometimes they don't need surgery. If this is just one vein and small segment of the right lung, they may not need surgery at all. If it's the whole right lung, they may need surgery for that. Depends on how big the shunt is. I showed this at the very beginning of the talk. Crab view. What's wrong with this? Left upper pulmonary vein, left lower pulmonary vein. What about here? There's supposed to be two veins there. No, they're not there. This is an adult. Here's the vein. Liver coming in below here. That was a lady who actually had ASD closure when she was a child, and scimitar vein was missed, and had that repaired later as an adult. I'm going to not touch on pulmonary veins anymore, switch over to systemic veins in just the last few minutes that I have. So, most common problem with systemic vein, left superior vena cava. Here is parasternal long axis. You can see dilated coronary sinus. If we go to the right lower picture, pulmonary artery, right pulmonary artery, left pulmonary artery. Left SVC runs anterior on top of the left pulmonary artery. And when you turn 90 degrees on this, you can see how the left superior vena cava joins coronary sinus. This is the roof of the coronary sinus. If you have two good-sized superior vena cava, right and left, you usually do not have an innominate vein connecting them. Okay, so that's one rule to remember. Also, always look for unroofed coronary sinus. So here is left SVC going to coronary sinus. This was contrast injection in the left arm. The whole left side of the heart fills with saline. So this was left SVC with unroofed coronary sinus. And you can make the diagnosis by injecting saline in the left arm. Don't confuse left SVC with this. This is the pericardial reflection. That's the aorta, okay? Coronary sinus sits anterior to the pericardium in the corner there. One other vein that we talk about is the innominate vein. It's supposed to be anterior to the brachiocephalic veins, the brachiocephalic arteries. It can be variable, sometimes behind, sometimes below the aorta, many different places. We can see this by echo sometimes. No innominate vein over the top of the aorta, it's actually below the aorta. Again, important to let the surgeons know about this because of problems with accidentally cutting into this if the pathway is variable. Last vein I want to talk about, azygos vein. It runs along the spine. It is posterior to the aorta. You can see it with CT in many pictures. Heterotaxy, very commonly. Polysplenia. More than half the patients will have interrupted IVC and azygos continuation. None with asplenia. But the other thing that's important is look at the anomalous pulmonary veins. Both of them have many anomalous pulmonary veins. The talk after this, I think, discusses heterotaxy patients and veins, so I won't talk about that anymore. Sometimes we create the problems with the veins by doing surgery, all right? So we talked about congenital anomalies, pulmonary and systemic. Sometimes we are the problem. We cause the problem. Patient with DTGA that had a mustard operation, not done so much anymore, was done frequently in the 1960s and 70s. Pathways, you can see the pulmonary venous pathway in the diagram and over here. You can also see IVC pathway over to the left ventricle over here. And in that diagram, this is MRI, and it shows very nicely normal SVC and IVC baffle to the left atrium. So typical patient who had mustard operation. But if this gets obstructed, like frequently they can, then we have other issues. So here is a Senning patient. The Senning patient had obstruction of pulmonary venous pathway. And then this is a mustard patient, and I'm not showing the SVC pathway very well, but look how big the azygos is. So if we see the azygos get so big, we worry that we have SVC obstruction. So something to keep in mind when we see abnormalities of these other veins. So to end with some pearls, make sure the atrial septum is the atrial septum when you're doing the imaging. And if you do echo in a newborn and say, oh, I see two pulmonary veins, great, congratulations, you're not done. You need to see all the pulmonary veins. If SVC is bigger than the aorta, figure out why. Why is SVC bigger than the aorta? That should never happen. And if you see continuous red flow towards the head from suprasternal notch, again, that something is wrong with the pulmonary veins. You need to check that some more. Just as an aside, if the patient has Turner syndrome, remember, pretty high incidence of anomalous pulmonary veins with Turner syndrome. And then heterotaxy, assume they all have anomalies. They all have anomalies of pulmonary and or systemic veins. Start there and make sure that you look at all of those things. So in summary, total or partial anomalous pulmonary veins we talked about. You need to be very meticulous imaging in all the planes. Suspicious if the right side is large and you don't see an ASD. Use TEE, CT, MRI if regular echo does not give you the answers. And remember some of the pearls. So, spasibo, it's been an honor